Okay. A very good evening. It takes me immense pleasure to introduce the speaker for today on our classroom series by Neurocritical Care Society of India. So we have with us today Dr. Francis, who specialty is in perioperative cardiology. So he'll be discussing about ECG in the Neuro ICU. Over to you, Francis, sir.
Thank you, ma'am. Thank you for the opportunity. I'll be talking about ECG in the Neuro ICU, and I'll be talking about it first in terms of the normal ECG, and I'll cover normal ECG over the first third of the presentation, and then I'll switch over to ECG in the Neuro ICU. So, what does the ECG measure? It plots the voltage on the y-axis and time on the x-axis. Voltage is a summation of electrical activation of all the cardiac cells at that time. Electrical activation of a single cardiac cell or a small group of cells does not produce enough voltage to be recorded on the body surface. Therefore, clinical ECG requires activation of large groups of atrial and ventricular cells. So how does the impulse form? There are special cells of the pacemaking and conducting system that are arranged in nodes, starting from the SA node, then going down to bundle branches, and branching networks of fascicles. The intrinsic pacemaking rate is fastest in the specialized cells in the atrium, slowest in the ventricles. And there is a balance that is struck between the sympathetic and parasympathetic autonomic nervous system. The SA node is located, as shown in the picture earlier, high in the right atrium near the junction with the SVC. It is a predominant cardiac pacemaker and it responds to autonomic input and controls heart rate. The AV node is situated lower down and it is adjacent to the interatrial septum. It slows electrical conduction sufficiently to synchronize the atrial contribution to ventricular pumping. Normally, it is the only structure that can conduct impulses from atria to ventricles because these chambers are separated uh, by non-conducting uh, tissue. So this is the pathway of electrical activation, starting off with the SA node high up in the atrium, going down towards the AV node, uh, and lower down to the bundle of His, bifurcating into the right bundle branch and the left bundle branch. The left bundle branch further bifurcates into the anterior and posterior fascicles, finally ending up in the Purkinje fibers, going into the ventricles. And how is it measured? It's measured by using both limb leads and chest electrodes. The chest electrodes are positioned as shown on the image, and you can see the position of the limb electrodes as well. Here, the voltages of cardiac currents are detected by each electrode, and you get a readout. So a lead is basically just the recording of the potential difference between two electrodes. There are 6 limb leads in the frontal plane and 6 chest leads in the horizontal plane. They are the nomenclature is 1, 2, 3 AVR, AVL, and AVF, and V1 to V6. The frontal leads consist of 3 standard bipolar limb leads, that's 1, 2, and 3, and 3 augmented unipolar limb leads, AVR, AVL, and AVF. This is how a grid on an ECG strip will look like, assuming that the speed is 25 mm per second. Each small box horizontally will measure 0.04 seconds, and each small box vertically measures 0.1 millivolt. Coming to the P wave, the P wave represents atrial depolarization or activation. It is monophasic in all leads except in V1. It is best seen in lead 2 because the direction of the depolarization vector of the P wave is roughly in the same direction as lead 2. Its axis is roughly between 0 and plus 75 degrees. And therefore, it is upright in lead 2. It's also usually upright in lead 1 and AVF. And it is in normal cases always inverted in AVR. V1 is another place on the ECG where we can look at the P wave, especially because it is situated at an inflection point where the first half of the P wave will represent right atrial activity and the second half represents left atrial activity, and therefore the P wave in lead V1 is biphasic. The amplitude is usually 25% of the R wave or less than 0.25 millimeters. So this is just a diagrammatic representation of how the vector moves, uh, the P wave vector moves, and how um, the the wave depolarizes as seen from lead V1 uh, from the right atrium down across into the left atrium. The PR interval represents the beginning of the P to the beginning of the QRS and includes both atrial depolarization and repolarization. The normal PR interval is 0.1 to 0.2 seconds. It's shorter in children, longer in elderly, and it is measured in the lead with the widest P wave or the longest QRS duration. PR interval of more than zero point 0.2 seconds signifies an AV block. QRS represents simultaneous repolarization or activation of the ventricles. It is the largest deflection in the ECG because the ventricles contain the largest mass of muscle cells. High frequency signals than P and D waves, thereby causing its contour to be peaked rather than rounded, and the normal duration is 0.07 to 0.11 seconds. Now, how does one name QRS complexes? Now, these are different morphologies of the QRS complex that you might see in any given ECG. The first negative deflection is always designated Q, and therefore, if there is only a negative deflection, then it is designated QS. If there is a negative deflection followed by a positive deflection, then the first positive deflection is named R. Uh, if it is a small negative deflection that precedes the positive deflection, then it is small q, capital R. And if it's a large negative deflection, then it is designated with a capital Q and a capital R. Um, if the QRS is triphasic, that is, if it has a negative followed by a positive and then a negative, then it is called a QRS. And if it is only positive, it is called an R. If the first deflection is positive and followed by a negative deflection, it's called an RS complex. And depending on the size of the deflection, you label it either capital R or small r. And if you see two positive deflections separated by a negative deflection, then the second positive deflection is designated R dash. So coming to Q waves should not be absent in leads V5 and V6. And usually Q waves of any size in lead 3 and AVR are normal. Q waves are enlarged in MI, where there is loss of myocardial tissue, or in hypertrophy of the ventricular myocardium, or in abnormalities of ventricular conduction, like interventricular conduction delays, bundle branch blocks, etc. ST segment represents ventricular myocardium early repolarization, and normal variants include slight upsloping, downsloping, or horizontal depression of the ST segment. Early repolarization causes displacement of the ST segment by as much as 0.1 millivolts in the direction of the ensuing T wave. Early repolarization syndrome is a normal variant. It's seen quite in especially in young patients, and usually is a benign finding. You will see ST segment elevation in almost all of the leads. What is a classic hallmark here is that usually there is no uh, ST depression, any reciprocal ST depression seen in any of the leads in early repolarization syndrome. So when is an ST elevation significant? Uh, an ST elevation is significant if it is more than 0.1 millivolt in all leads except in V2 and in V3. In V2 and V3, the following cut points apply. That is, if it is more than or equal to zero point 0.2 millivolts in men more than 40 years, 0.25 millivolts in men less than 40 years, and more than equal to 0.15 in women. Now, the T wave represents ventricular repolarization or recovery. Its amplitude diminishes with age. It's larger in men. T wave amplitudes do not normally exceed 0.5 millivolts in any limb lead or 1.5 millivolts in any precordial lead. It is asymmetric. The slope of ascent is more gradual, and it is usually upright in 1 and 2 and inverted in AVR. T wave is always upright in left precordial leads. The nomenclature is that V1 to V4 are the right precordial leads and V5, V6 are left precordial leads. U wave is seen at the onset of ventricular relaxation. It is normally either absent or is present as a very small wave following the T wave. It's 10% of the amplitude of the T wave, and it's oriented in the same direction. It's most prominent in V2 and V3, and it is larger at slower heart rates. At faster heart rates, it will merge with the following T wave. The QT interval is important, especially in the context of neurocritical care, and I'll come to that in my subsequent slides. The way to measure it is by drawing a tangent across the T wave steepest portion at the terminal point, and the point where it crosses the isoelectric line is the terminal part of the QT interval. QT interval varies with heart rate, and therefore it has to be corrected for heart rate. The most common formula is the Bazit's formula. And the upper limit, depending on which book you read, is 0.46 seconds and slightly longer in adult females. So I'll come now to the crux of the topic, which is ECG specifically in neurological disorders. The heart-brain axis can be approached as either effects of cardiovascular disease on the nervous system, such as cardioembolic strokes and atrial fibrillation, or as effects of neurological disorders on the cardiovascular system, such as stress cardiomyopathy after aneurysm, SH. There are certain characteristic ECG changes that are seen in strokes, and in ischemic strokes, especially, you will see QT prolongation and ventricular dysrhythmias, especially in lesions involving the right insular cortex. In various animal experiments, it has been shown that stimulation of the caudal and rostral posterior insula decrease and increase heart rate, respectively. Stimulation of the posterior insula caused AV block that progressed to complete heart block. It also caused QT prolongation, and stimulation of the right and left insula leads to increased sympathetic and parasympathetic tone, respectively. ECG changes in stroke patients can also be seen because these patients usually have common comorbidities associated with heart disease, such as hypertension, diabetes, dyslipidemia, coronary artery disease, and these patients may be on QT prolonging medication as well. Ischemic strokes are characterized by catecholamine surges as a result of acute cerebral injury, leading to cardiomyocyte necrosis and stress cardiomyopathy, which may manifest on the ECG as well. So these are the common features of ECG changes in CVAs, starting from the most frequently seen changes, which would be the widening and deepening of T waves in precordial leads. QT prolongation is also fairly common. You will see an increase in U wave amplitude as well, especially in these patients who develop bradycardia. Bradycardia is also very common because of Cushing's reflex. ST elevation or depression, mimicking an MI, can also be seen. These are three ECGs taken from three middle-aged ladies who all presented with ischemic strokes. You can see that all of them have repolarization abnormalities. The first ECG you can see from starting from V3 down to V4 and V6, you can see T wave inversions, and you can see ST changes as well in lead 2 and lead 3. In the second patient, you can see in V3 to V6 tall T waves, tall peaked T waves. And in the third patient, you can see very, very deep T inversions, again in V3, V6, and lead 2 and lead 3. This was a recent article published in the Journal of American Heart Association 2023, January, which studied the in-hospital ECG findings, changes in medical management and cardiovascular outcomes in patients with acute strokes or TIAs. 3,465 patients were randomized 1:1 to continuous Holter ECG recording for up to 7 days during the in-hospital stay, and at least one ECG abnormality was detected in almost 20% of the intervention groups. The common ECG changes ranged from non-sustained ventricular tachycardias to atrial fibrillation, supraventricular tachycardias, and even pauses. Pauses uh, for more than 5 seconds where there is absolutely no electrical activity uh, necessitate pacemaker implantation. AV blocks were less frequently seen in the studied population. I'll go over the morphologies of all of these ECGs in brief in the coming slides. This is another study published 3 years ago in the Neurocritical Care Society journal, which assessed the predictors of ventricular dysrhythmias in neurology intensive care unit patients who had prolonged QT on their ECG. And this is a small study which studied only 171 patients at Wake Forest Baptist Medical Center. And they found that the risk factors for developing ventricular dysrhythmias include long hospitalization stays, more than 10 days, a QT of more than 592 milliseconds, supratentorial ischemic strokes, and multiple VPCs on the ECG. So, what are VPCs? VPCs are ventricular premature complexes. They are characterized by absent P waves preceding the complex. They are wide and they are bizarre. They, they do not resemble the normal sinus complex. And usually, though not always, they are followed by a compensatory pause. What that means is the RR interval straddling VPC is equal to the RR interval straddling a normal complex. Um, they come in various forms. You will see VPCs presenting. I have put up a picture of a ventricular trigeminy where a VPC appears uh, in every third beat. If a VPC appears at every second beat, it's called ventricular bigeminy. These patients are usually treated and do well on beta blockers. Uh, this is a slightly more malignant rhythm where you have VPCs coming one after the other. If you have two consecutive VPCs, they're referred to as a PVC couplet. And if you have three consecutive VPCs, they are called a triplet. Four or more becomes a non-sustained ventricular tachycardia. So non-sustained VT is basically a run of VPCs, but lasting less than 30 seconds. And they obviously carry a poorer prognosis. So what are ventricular tachycardias? They are characterized by very broad QRS complexes, more than 160 milliseconds. There is AV dissociation. That is, you may not be able to see the P wave, and when you do see it, there is no association between the P and the QRS complex. They may be monomorphic, where the morphology is the same in all the complexes, or they may be polymorphic, where the morphology varies, and they may be sustained or non-sustained, as I mentioned earlier. There's a characteristic VPC here. You can see the characteristic wide QRS complex and complete absence of AV association. There is complete AV dissociation. You also see this little notch over here. This is called the Josephson's notch. It's a notch on the downstroke of the S wave. The another pathognomonic feature of ECGs are fusion of VTs are fusion beats and capture beats. A fusion beat is narrower than normal complex. It is a product of both the sinus node and the ectopic ventricular focus merging together. And the capture beat again is a narrow QRS complex. But here the atrial impulse has made its way through and it has gotten conducted to the ventricles normally, resulting in what is almost a normal looking QRS complex. Other features are the Josephson sign, which I have already mentioned, and the Brugada sign, which is a distance from the onset of the QRS complex to the nadir of the S wave of more than 100 milliseconds. Another common uh, ECG finding in patients with CVA is atrial fibrillation. Atrial fibrillation is characterized by uh, fibrillatory waves or F waves seen on the baseline. There is no real discernible P wave here, and the rhythm is irregular. Uh, so here I have just put up a 12 lead ECG which is showing atrial fibrillation, and heart rate calculation here is not calculated in the normal way, where you divide 300 by the number of big boxes of 1500 divided by the number of small boxes. Here, heart rate calculation is you count the number of QRS complexes in the long 10-second recording, and you multiply that by 6 to get the heart rate. Atrial fibrillation, early studies have found that prolonged Holter monitoring even after hospital discharge increased the AF pickup rates. And some studies found that up to 12% of patients who had CVAs had undetected atrial fibrillation that was revealed only on prolonged Holter monitoring. Um, and atrial fibrillation warrants anticoagulation. However, two large trials, that's the RESPECT trial and the NAVIGATE trial for embolic stroke of undetermined source, found no therapeutic benefit of starting either dabigatran, rivaroxaban, or antiplatelet medication. This is slightly a very common ECG finding in patients with atrial fibrillation. You will find that sometimes these patients take an extra dose of a beta blocker, and then they come with this rhythm. So here the rhythm is regular. Again, you can see the fibrillatory waves on the baseline fairly clearly. So this is basically an atrial fibrillation with a complete heart block and a junction. So what is a complete heart block and what is a junctional rhythm? So complete heart block or a third degree AV block is when there is failure of all atrial impulses to conduct to the ventricles. The P waves are unable to reach the ventricles because they're blocked somewhere in the AV conduction system. And unless an escape rhythm comes to the rescue, the ventricles remain asystolic. An escape rhythm is sort of like when you lose electricity and your backup generator, UPS comes on. It's kind of like that. And the origin of the escape rhythm will depend on the location of the AV block. So here, the since the SA node is not able to conduct, the either the AV node or the AV junction takes over pacemaking duties, or the ventricular uh, cells take over pacemaking duties. So in an AV junctional escape rhythm, the origin is from the AV node to the bifurcation of the bundle of His, um, and any impulse originating above the bifurcation of the bundle of His can activate both ventricles simultaneously. Therefore, the complexes you will see here are narrow complexes. If the AV junction is suppressed or inhibited or structurally normal, then a ventricular escape, that is a backup to the back, will come to the rescue, in which case you'll see broad QRS complexes. The rates of discharge from the SA node are normally 60 to 100, and the AV node, once it takes over, discharges normally at 40 to 60, and the ventricles discharge at 20 to 40. You would have seen you would have seen nomenclature accelerated junction rhythm, which is nothing but when the AV node is beating at a very high, at a higher than normal rate, that is at a rate of higher than 60, usually due to enhanced automaticity. That's called accelerated junction rhythm. So this is an example of another example of complete heart block. Here you can see that the QRS is wide, it's regular, it comes at regularly spaced intervals. And the P wave doesn't seem to have any relationship with the QRS complex, often described as the P wave marching through. So we've covered complete heart block, and we'll move on backwards now to second degree AV block, or Mobitz type 1 or Wenckebach AV block. uh, not so commonly seen after CVS, but still worth mentioning. Um, the stimulus here from the atria encounters progressively more difficulty in traversing the AV node en route to the ventricles. And finally, an atrial stimulus is not conducted at all. And therefore, an expected QRS gets blocked. You can see here that the PR interval is progressively lengthening, and at one point of time, the P wave is not conducted and therefore not followed by a QRS complex. Um, the Mobitz type 2 AV block is rarer but is more serious and may warrant a pacemaker because there's a high chance that these can deteriorate further into complete heart blocks. Here, the PR interval is fairly constant, but then suddenly you will see the appearance of a single non-conducted P wave as seen over here. Supraventricular tachycardias are also seen in CVAs, and the most commonly seen is atrioventricular nodal reentrant tachycardia, AVNRT. It is a narrow complex tachycardia with regular RR intervals and no P waves. In fact, most narrow complex regular tachycardias are AVNRT and can safely be diagnosed as such. Um, uh, when P waves are present, they are always retrograde because the atria are activated from below upwards. So here the vector of depolarization uh, is in opposite direction to how it normally is, and therefore the P wave will be inverted in the leads where it would normally be upright, that is in leads 1, 2, and AVF. Retrograde P waves may also be present but not visible. That is when they are embedded within the QRS complex. Um, and when the retrograde P waves distort the terminal portion of the QRS complex, they can be mistaken for S waves in lead 2, 3, and AVF, where they are called pseudo S waves. They can be mistaken for R dash waves in lead V1, where they are called pseudo R dash waves, pseudo R prime waves, and they can be mistaken for Q waves in lead 2,3 AVF, where they are called pseudo Q waves. Slightly more rarer manifestations of retrograde P waves are where they may be inscribed immediately after the QRS complex, deforming the ST segment or even the T wave. And if the retrograde P wave is inscribed before the QRS complex, which is rarer still, it's called an atypical AVNRT. This is a 12 lead ECG showing the pseudo S wave here seen in lead 2 and lead AVF, and the pseudo R dash wave seen in lead V1. Coming to epilepsy, in epilepsy, again, you will see a lot of depolarization changes in patients with epilepsy. T wave alternance or global T wave inversions can be seen. ST elevations or depressions, shortened QT, especially in the immediate post-ictal phase, can be seen. And sudden unexpected death in epilepsy can be seen due to drugs prolonging QT or underlying long QT syndrome. It's also seen in patients who develop severe bradycardia with sinus arrest. Periictal bradycardia is common in temporal lobe seizures, and some ictal bradycardias may warrant permanent pacemakers. This is a classical T wave alternance where you can see every alternate T wave amplitude um, varies. You can see global T inversion. There have been various trials that have attempted to find ways to identify seizures even before they happen. And some of them have involved ECG monitoring as well. And this is one slightly old article published in the Journal of Electrocardiography, where single lead ECGs were recorded from 37 patients suffering from both focal and generalized seizures, and two algorithms were proposed. One was an algorithm which quantifies changes in QRS morphology, and the other that assessed cardiorespiratory interactions using phase rectified signal averaging. Positive predictive values of 86 and 77% and sensitivities of 100 and 90% were achieved for focal and generalized seizures. Of course, the sample size was fairly small. But subsequent trials have also used biomedical signals for monitoring epileptic patients. using machine learning models, analyzing various other aspects like heart rate variability, and EEG, photoplethysmography, and this is still an area of ongoing research. In GBS, you will see autonomic nervous system dysfunction where there is alternating sympathetic and parasympathetic hyperactivity. And you'll see a broad range of arrhythmias. No pathognomonic arrhythmia here. You will see everything from severe bradycardias to AF and VT. Asystole is common at tracheal suction, and it's been mentioned in the new edition of Braunwald. Myasthenia gravis patients develop myocarditis, especially those with thymoma, and myasthenic crisis has been associated with stress cardiomyopathy. Here again, you'll see a wide range of arrhythmias from AF, AV blocks, asystole, and VT. This was a study, and it's a slightly old study conducted in Japan, Kyoto University, between 2011 and 2013, studying 178 patients with myasthenia gravis. 58 of these patients had an ECG taken, and these patients had repolarization abnormalities, AV blocks, and some had AF as well. Echoes were also done in all these patients, and a significant amount of them had echocardiographic changes as well. In traumatic brain injury, there are various proposed pathophysiological phenomena that cause ECG changes. The most widely accepted one includes sympathetic storm causing catecholamine release from the adrenals neurally and from exogenous catecholamines, which activate calcium channels and cause ECG changes, which can lead to severe cardiac death, and free radical release causing calcium entry, enzyme leak, and contraction necrosis. ECG changes in descending order include prolonged QT, transient T wave inversions, and decreased heart rate variability is a correlate of cardiac autonomic regulation, um, and is a marker of poor clinical prognosis. In raised intracranial pressure, you will see widespread giant T wave inversions. They're also called cerebral T waves. You will also see QT prolongation. You'll see bradycardia, and this 12-lead ECG is classical cerebral T waves. It's worth mentioning myocardial injury after non-cardiac surgery, or MINS, which is a fairly recent uh, introduction in the glossary of myocardial infarction. It started off in 2016, where the Canadian Cardiology Society's first proposed guidelines about how to detect perioperative myocardial injury by monitoring serial troponin measurements both pre and post-operatively, and it was subsequently adapted even by the European Society of Cardiology in the recent 2022 guidelines. Um, what has been found in all kinds of surgical patients, this is including neurosurgery patients, where elevated post-operative troponin with or without ischemic signs and symptoms. These patients are generally on opioids and may not exhibit signs, or may not exhibit symptoms. And these patients can have elevated post-op troponin because of myocardial injury during the first 30 days after any non-cardiac surgery. And therefore, in these patients, ECG monitoring is a must. And especially in the first 48 hours post-operatively, an elevation of cardiac of troponin T or troponin I, um, especially in patients who are at high risk for developing cardiovascular disease, uh, sure is a significant indicator of myocardial injury. And the ESC guidelines mention that all patients above the age of 65 and all patients above the age of 45 with at least one cardiovascular risk factor should have serial troponin measurement done. These patients also should have ECG. ECG is being monitored because any dynamic change can be indicative of myocardial damage. Coming to the last part of the topic, which is the ECG manifestations of drug toxicity, and um, drugs used in psychiatric practice can prolong QT interval, which predisposes to torsades like ventricular tachycardias. These drugs include atypical antipsychotics and tricyclic antidepressants. And I'll give you two examples. It's a patient, 17-year-old who overdosed on clozapine. You can see sinus tachycardia with prolonged QT intervals. And since on monitors it's very difficult to measure corrected QT, a rough rule of thumb is if the end of the T wave is more than half the RR interval, then it's safe to assume the patient has QT prolongation. In TCA overdose, tricyclic antidepressant overdose, because of fast sodium channel blockade, there will be interventricular conduction delay. QRS is more than 100 milliseconds, especially in lead 2, and in all leads, you will see a widened QRS complex of more than 120 milliseconds. You will also see a terminal R wave of more than 3 mm in AVR, or an RS ratio of more than zero point 0.7 in AVR. You'll also see sinus tachycardia in these patients. This is a 12-lead ECG, again showing an RS ratio of more than zero point 0.7 and tachycardia in prolonged. Thank you.
Thank you, sir. Thank you for this very lucid presentation on behalf of NCSI. We are looking forward to many more heart brain interactions with you in the future. Thank you so much for your wonderful talk.
Thank you, ma'am, for the opportunity.